We present an interesting case of tension pericardial abscess resulting in cardiac tamponade. So a 24-year-old man presented with the 5-day history of shortness of breath, dry cough and chest pain. He had a history of lymph node tuberculosis which was treated with anti-tuberculosis medication. On presentation, he had tachycardia, pulsus paradoxus, muffled heart sounds and distended jugular veins. On chest X-ray, as you can see, there was enlarged cardiac sellout with a large air fluid level in the mediastinum. Echocardiography revealed a massive pericardial effusion with early diastolic right ventricular collapse and late diastolic right atrial collapse. A contrast CT scan confirmed the finding of massive pericardial effusion completely encapsulating the heart, along with a large air fluid level in the mediastinum. There were few centrally necrotic enlarged mediastinal lymph node, but no fistulous communication with the airway or esophagus was noted. There was right-sided pleural effusion without any parenchymal disease. So a diagnosis of pericardial abscess causing cardiac tamponade was established. We drained approximately 700 ml of purulent fluid, which resulted in immediate symptomatic improvement and started the patient on intravenous antibiotics. We had planned to carry out the culture sensitivity testing of the drained fluid, but the patient left the hospital against medical advice before further testing could be carried out. So a purulent hydropneumopericardium is an extremely rare cause of cardiac tamponade, which can occur secondary to prior instrumentation, a direct or hematogenous spread of infection, or a penetrating trauma. A late paradoxical reaction of the lymph node causing pericardial effusion has been described, but an acute presentation along with the pericardial collection of pus which was seen in our patient would suggest this source unlikely. Moreover, there was no history of prior instrumentation or penetrating trauma, so we concluded that a secondary infection by a gas-producing bacteria was probably the cause, since Mycobacterium tuberculosis does not produce gas. Similar to any other case of cardiac tamponade, the pericardial fluid should be drained as soon as possible and the patient should be started on broad-spectrum antibiotics.